Today our topic is bilirubin metabolism and jaundice. Very important topic. Already in our last class, how bilirubin is formed, where from bilirubin comes, that we have already discussed. Today I will be repeating. Okay. Uh, Definitely, have you ever seen the jaundice patient? Seen? What happens? How do you identify the patient is having jaundice? Oh, yellow sclera, yellow skin, yellow. Okay, so yellow colored stool or whitish stool and pale stool and urine is also pigmented. I mean, this is also yellow in color. So by that we understand the patient or the person is suffering from jaundice. Now, what is this yellow colored pigment? That is, you can see in the sclera of eye, in the skin of your body. What is this pigment? Bilirubin. Okay. So bilirubin metabolism means how this bilirubin is produced, how these are processed, and how these are eliminated. So all this together comes under bilirubin metabolism. Okay? So bilirubin comes from, what is the source of bilirubin? Where from it comes? From where bilirubin is derived? Huh? Hemolysis of RBC. That is, you see, it is derived from hemolysis of RBC. What comes out? From hemolysis for breakdown of RBC, what comes out from within the cell? From the cell? Hemoglobin. Okay, so hemoglobin is the source of bilirubin. So there must be a path by which hemoglobin is converted into bilirubin. Now then we'll see what happens to this bilirubin. Bilirubin are of two types, isn't it? Two types. One is free, and this free bilirubin is called unconjugated bilirubin, or another term is there, indirect bilirubin. So all are synonymous. What is this? Free bilirubin means free bilirubin. It is also called unconjugated bilirubin. It is also called indirect bilirubin. This bilirubin is toxic. We have discussed in our earlier class. This is very toxic for the brain cells and other cells. So it must be eliminated. Not only this bilirubin is water insoluble. Since it is water insoluble, it can pass through the cell membrane. This is water insoluble means soluble in lipid, so it can enter easily. This toxic substance can enter within the cell and it can damage the cell. So it has to be eliminated. How these are eliminated? First, this bilirubin, free hemoglobin, unconjugated bilirubin has to be conjugated. And what is the benefit of conjugation? One benefit is these are less toxic and water soluble. These are less toxic and water soluble. So since it is water soluble, it cannot penetrate all cells. So in that way, we can prevent the toxicity of bilirubin. Okay? We have seen when an RBC is destroyed, hemolyzed, for two reasons. Two main reasons. One is because the cell itself is having problem. Okay? It is abnormal or it is senile. It is aged. Okay? So fourth is intrinsic within the RBC. Okay? Another thing is there, RBC is okay. Some external factors, for example, snake bite, spider bite, they are having poisons. So they can cause injury, they can cause hemolysis, breakdown of the RBC. There are some other factors. We have discussed all these factors yesterday in our previous class. Today also I will try to cover some part. So, RBCs, when they become agile or when these are defective, say defective in spherocytosis, okay, in another condition, a cell becomes sickle cell. RBC become sickle cell. Why? Because the hemoglobin that is crystallized. Normally these are not crystallized. Hemoglobin are crystallized and stacked, giving a shape of the, in the cytoplasm it gets a shape. So because it's a sickle cell, accordingly size or shape of the morphology of the RBC is also changed. So whole RBC becomes sickle shape, and this is abnormal in shape. Since it is abnormal in shape, it cannot pass through the capillaries. As a result, they are hemolyzed and down. Okay, because of this, the hemoglobin comes out of the cell, enters into what is there in blood cells outside. When hemoglobin is coming out, where they will enter? In the plasma. Now, what will happen to this hemoglobin? So, this is for abnormal hemoglobin. For normal hemoglobin, for external hemoglobin, external factors, there can be lysed, the RBCs can be lysed. In such condition, also hemoglobin will come out. So, in this way, we can get hemoglobin out of RBC in the plasma. So, when the level is raised, a condition is called hemoglobinemia. Increased level of, normally the, say daily in our body 6 gram of hemoglobin is degraded and 6 gram of hemoglobin is produced. As a result, our body maintains a normal level of hemoglobin, and this degraded hemoglobin comes from agile RBCs who have already spent their life, one for 20, how many days? Already they have spent. Now they are useless. So they are to be destroyed, and from them the hemoglobin has to, this is important, and globin is also important. So they are to important because they are to be taken out and they are to be metabolized. Okay, so in this way, various means we get what? Hemoglobin. Now what happens to this hemoglobin? Now hemoglobin came out of RBC. Now what happens to this hemoglobin? How this will be metabolized? Hemoglobin, write it down, hemoglobin, once it comes out of the cell into the plasma, one carrier, it will carry this hemoglobin to the place where it will be metabolized. Haptoglobin. It is, the carrier is H-A-P-T-O globin, haptoglobin. Okay, H-E, haptoglobin. Okay. So now this haptoglobin will bind this hemoglobin and take it to the cell where it will be, the hemoglobin will be further degraded. And what is the site where it will be degraded? Only one site. That is macrophage. Now this bilirubin will be treated, will be processed where? In macrophage. Where do we find these macrophages? two types of macrophages, wandering macrophages, tissue macrophages. They are protective in nature. They protect our body from various diseases, from abnormal conditions. They are present in spleen, they are present in liver, they are present in bone marrow, they are present in endothelial cell lining, they are present in our skin, everywhere they are present in brain, everywhere they are present and protecting us. So these macrophages are very first line of defense of our body. Understood? So now, these macrophages which are responsible for degradation of hemoglobin, where you will find them? You will find them in three places. What is this? The most importantly is spleen. Most importantly is where? Spleen. Then in liver. When you will be studying the histological structures of liver, you will find that the liver is made up of huge numbers of lobules, hexagonal shaped lobules. So within this lobule there are central veins. From the central veins there are radiating columns of hepatocytes towards the periphery of these lobules. Okay, so in between the two cords, there is a space. This space is called sinusoids. This space is, so this is one cord, this is another cord, in between the cords there is a blood-filled space. This blood-filled space is called sinusoids. It remains filled up and it is connected to the central vein. It drains, central vein gets its blood from the sinusoids. Where from the sinusoids gets its blood? Remember, every organ of our body has single supply of arterial blood. Arterial blood supplies every organ. But our liver gets blood supply from two sources. One is hepatic artery and another is portal vein. Sir, what is this portal vein? What is the function of this portal vein? Okay? So today while coming, I took some food. And these are complex foods. And since these are complex, they cannot be absorbed in my blood. So what I did? I digested it, made it into simpler form. Now, in the GI tract, simple nutrients are formed. From carbohydrate, glucose is formed, from protein, amino acids are formed, from fat, fatty acid, glycerols are formed. So these are simple food, simple nutrients. So this can easily enter in my blood. Which blood vessel, which circulation will carry this and where they will go first? From our GI tract, this food in our GI tract, they may contain, absorbed food may contain some toxic substance, some unwanted thing that I have absorbed from my stomach, from my intestine. So that has to be treated first. So where they will be? What is this organ? Where this blood will go first, carrying all this material from GI tract? A liver. Okay, so from liver, this blood will enter into the liver. Okay, so after entering there, okay, too much of glucose, but my body doesn't require this. So what I'll do? I'll store it in the form of glycogen, and the required amount will send it to the circulation. Okay, similarly, lot of amino acids are there, I'll store it. Lot of vitamins are there, I'll store it for future use. Lot of iron has been absorbed, I'll store it for future use. Lot of toxins are there, abnormal things are there, I'll destroy it. So in the liver, to destroy this, detoxify this, there are also macrophages. This macrophage is called Kupffer cells, and these Kupffer cells are present within the sinusoids. They are moving there. If any Abnormal things comes in the through blood, immediately it will trap it and destroy it. Okay? So in the liver, you will get Kupffer cells. These Kupffer cells are macrophages. And this macrophage can also identify, since blood is coming into the sinusoids through portal vein as well as through artery, hepatic artery, they are mixed. Both these circulations, both this blood are mixed in the sinusoid. Then they are drained into the central vein. So while they enter into the sinusoid, so what happens? There also, if they find any abnormal red cells, these macrophages will engulf. They will phagocytose. Similarly, if they find there is hemoglobin, free hemoglobin, carried by haptoglobulin, they will take up this hemoglobin and will process to form bilirubin. Okay? It is where, it took place where? In liver. In liver. Now let us see what happens in spleen. Spleen is having, when you will be studying the structure of spleen, you will find there are red pulp, white pulp. In the red pulp is made up of unique thing. Some capillaries are, these are not normal capillaries. Some capillaries are blind capillaries, and their wall, capillary endothelium, this capillary is lined, this is called sheath, S-H-E-A-T-H-E-D, sheath means covering. Sheath capillaries. And what is this sheath? These sheath are nothing but lined macrophages. So whenever any blood comes through this capillary and there is abnormal red cells, abnormal hemoglobin or hemoglobin carried by haptoglobulin, they will be taken up by these macrophages. Okay? And they will metabolize it. They will degrade it. They will process it. Okay? To make it less toxic. Okay? See, as I said, in the spleen. So this is the spleen and this is the capillary. See, these are sheath. What are these? Macrophages. So if they get any senile RBC is passing through, this macrophage will take up this for further metabolism. Got it? Okay. Then, after this, here are the splenic cords. And I said this capillaries are blind. So this blood, after this blood will enter the cords, from this cord will into the vein. And they will come. Now this vein is having no abnormalities. This vein, the blood is, any abnormal thing that's been taken up by the macrophages. Okay? As I said, these are the central, this is section of liver. This is one of the lobule. These are the hepatic cords lined by hepatocytes. These are the enlarged view. And these are the hepatocytes, and this is one cord, this is another cord. In between the cord there is sinusoids. In between the sinusoid, blood is flowing. This blood is coming from hepatic vein and portal vein, and they will be drained into here. Now see, this sinus is lined by endothelial cells. These are the endothelial cells. And these endothelial cells are having gapped, fenestrated. Large molecules can pass through it. This is unlike any other endothelial cells. Here you will get more. Gap is more. Fenestra is wider. So that larger molecules can enter within this, through this. And these are, I said, the hepatic cell. And see, what are these? Kupffer cells. The green color cells are Kupffer cells. What are the Kupffer cells? Macrophages. Okay, now this in the liver, this macrophage we will treat hemoglobin, released hemoglobin, or abnormal cells. They will be taken up by this. Could you follow this up to this? Okay, fine. So in this way, they can take up, macrophages can take up what? They can take up released hemoglobin. After hemolysis, it is released and bound to a protein, haptoglobulin. So they can take up hemoglobin bound to haptoglobulin. So after when they take it up, haptoglobin will be released, only the hemoglobin will be entering here. So this is one source. Another source, they saw one abnormal RBC is going on, senile RBC is going. Immediately they will trap it. How they trap it? In our earlier class, phagocytosis, we have explained in detail. Try to remember those processes of phagocytosis. Fusion with what? One is polysome, and this is attached to the bag of enzymes. These enzymes, when fused with these phagosomes, then these enzymes will destroy all this. The RBC is having hemoglobin. So, okay, your hemoglobin, come here, you hemoglobin. Separated. Okay, RBC, then splitted, hemoglobin came out, then it broke the hemoglobin into heme and globin. Globin, this will be hydrolyzed into amino acids and it will be released in the plasma and it will be utilized for future use for the synthesis of protein. Then heme. Let us see what happens to the heme. We'll take up the heme. Means post-processing of heme. Where it will take place? In the macrophage. Remember this. So, macrophage. It will enter into macrophage will convert heme. Heme, 4 pyrrole rings, attached by methane bridges, and here is the iron. So this is the heme. Now within the macrophage, first thing is hotao. So आयरन मैक्रोफेज से बाहर आ गया, कहाँ जाएगा? प्लाज्मा में. In plasma there is one protein. To carry this protein, this iron for storage in liver. And what is this? Apoferritin. So after combination they will be forming ferritin and it will be stored in the liver for future use. Okay? Who processed it? Again, macrophage. Now what is retained? Heme, porphyrin. Now, this porphyrin will undergo change. What change? This will be broken, so it will be straightened. This is nothing but bilirubin. So from heme, hemoglobin, heme plus globin, from heme, porphyrin plus iron, from porphyrin, bilirubin. Okay? Now this bilirubin will be converted into bilirubin by bilirubin reductase. And first enzyme was heme oxygenase. First enzyme was heme oxygenase and after that reductase. What does this reductase do? After straining this bond, here is a double bond. If I can add two hydrogen atom, then there will not be this double bond. That's all. Now it is converted into bilirubin. So now remember the step. What happens in the macrophage? Hemoglobin released, split it into heme and globin. What happened to globin? You know that. And now the heme, iron will be removed, and splitting of this, as a result, what will be formed? Biliverdin. Now biliverdin will be converted into bilirubin. But this is the job of the macrophage. The function of macrophage ends here in bilirubin metabolism. Okay? Now this bilirubin, as I said, is toxic, water insoluble, soluble in fat. So this toxicity has to be removed. Okay? And they must be made water soluble. So what can be done? Macrophage, I can do anything. Go out of my body, of my cell. So where they will enter? In plasma. Now in the plasma there is a carrier protein, albumin. Now this albumin will bind to this toxic substance will make the compound water soluble. You can say, sir, now it is water soluble. Since it is toxic, water soluble, we don't want it, it can be excreted by the kidney. Isn't it? But kidney cannot excrete it. Why? You must have this question. Why it cannot be excreted? You will find glomerular capillaries. Their endothelial lining is not so big, through that this protein can be filtered. This albumin cannot be filtered. Size is big. Albumin is size of the albumin plus is big. So they cannot be filtered. But, so kidney is not the way. Then what to do? How to process it? Then, okay. Our liver is there. Send it to liver. Through blood, along with albumin, it will enter into the liver. Fine. Let us see in hepatocytes what happens. So anyway, through albumin plus bilirubin bilirubin in the sinusoid, albumin is released. Bilirubin enters into the hepatocyte through a carrier. Write this carrier. What is this carrier? OATP. 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 What is OATP? Organic, anionic, anion transporting polypeptides. With the help of this, without this it is not possible. With the help of these two proteins, the bilirubin is entered within the hepatocyte. Okay, so in any pathological condition, hereditary condition, if these proteins are not synthesized, it may happen. In hereditary disorder, it may happen. Then what will happen? It will not be able to enter. Okay, so this is a disease, hereditary disease. It cannot enter. Okay, with the help of this, they enter. So within this hepatocyte, there is endoplasmic reticulum. There is endoplasmic reticulum cells, proteins are synthesized there in endoplasmic reticulum. Not only this, steroids are produced there. Okay, so this bilirubin, free bilirubin, will go to the endoplasmic reticulum. How? How? Again, these are within the cytoplasm. Again, albumin is not there. Again, water insoluble. So what to do? They will take the help of two proteins. One is ligandin, another is protein Z. with ligandin, they will attach to the ligandin, and with this protein jet, they will be carried to the endoplasmic reticulum. Now, what will happen in the endoplasmic reticulum? Endoplasmic reticulum has two enzymes. These enzymes will add one thing, glucuronic acid. What? Glucuronic acid into the bilirubin to make it conjugated. Glucuronic acid and bilirubin, they together will form glucuronide, monoglucuronide. And the enzyme is glucuronide, UDP glucuronide transferase. UDP glucuronide transferase. You will find the total steps. Okay, UDP glucuronide. Now this UDP glucuronide, another molecule will be added by the same enzyme, UDP diglucuronide. So this bilirubin diglucuronide means bilirubin, in bilirubin 2 glucuronide had been added. As a result, the bilirubin became conjugated. It was unconjugated, now it is conjugated, now it is less toxic, now it is water soluble, and no further metabolism will take place within the hepatocyte. Now the function of this cell is to eliminate it. Okay? How they will be eliminated? These are the hepatocytes. This is the apical side of the hepatocyte. This is the sinusoidal, basolateral side. Basolateral membrane, apical membrane. So here bilirubin entered through basolateral membrane. Okay, so it has produced bilirubin, conjugated bilirubin. Now this conjugated bilirubin will be pushed, dhakka, pushed. Why push? Pushed needs energy. Pushing needs energy. Means this is an active transport. ATP will be required. Why ATP is required? Because this has to go against concentration gradient. Against concentration gradient. If anything comes, if any abnormality develops here, will this conjugated bilirubin will be going to the bile duct? No. Can it be eliminated out of the cell? No. So they will be deposited within the cell. So this is a pathological condition. And the cell, hepatocyte has got a capacity to store it, to hold it. So some amount of this will be eliminated into blood. Okay. The hepatocytes is not now capable of working. So will there be entry of bilirubin? Hepatocytes abnormal. Will there be entry of bilirubin? Unconjugated bilirubin free? No, because the cell is not working. As a result, the blood levels of bilirubin will be raised. Isn't it? Again, okay, cell is okay. Cell formed conjugated bilirubin, but it is unable to go out. As a result, there will be storage of this conjugated bilirubin. Not only this, from here it will be diffused again into the blood. As a result, when blood will be tested under this condition, what you will get? Conjugated as well as unconjugated bilirubin you will get in the blood. What does it indicate? Your liver cell is not working. Your liver cell is not working. Liver is making the conjugated bilirubin, but it is unable to secrete it. Unable to secrete in bile. So secretion of these bile into this bile canaliculi, it also takes place with the help of MRP2. What is MRP2? Multi-drug resistant associated protein. Without this pumping of conjugated bilirubin into the blood is not possible. So there can be a genetic disorder. So in such genetic disorder, elimination of excretion of conjugated bilirubin is not possible. We will come into this, what are these diseases. Now, okay, the cell is under normal condition. The cell is under normal condition. Normally, cell is dying. So normally, heme is taken up, hemoglobin is taken up, bilirubin is produced, conjugated bilirubin produced. They are eliminated through bile. They are eliminated through bile. Now, through bile, conjugated bilirubin is coming to intestine. Now, what will happen in the intestine? What will happen in the intestine? In the intestine, this bilirubin will be coming from that bilirubin, conjugated bilirubin that has entered intestine, that will be changed by the bacteria into urobilinogen. Now this urobilinogen, 80% of the urobilinogen will be passing through the stool. 80%. And this is in the form of starcobilin. And rest 20% will be absorbed by the portal system. Portal blood will be absorbed, and this absorbed fat will enter into the liver again. In intestine, what has entered? Conjugated bilirubin. Bacteria converted into urobilinogen. So part of the urobilinogen again will be absorbed into liver through portal duct. Again, the liver will release it through bile, and part of this urobilinogen will come to the kidney. This kidney will convert it into urobilin, and it will be excreted through urine as urobilin, and you will give your urine a color. So this is all about the metabolism of bilirubin. Okay, now we are coming to the next part. Just you take this and go through this. Everything will be clear to you. So this is the path. Jaundice. What is jaundice? Who can define? Jaundice is the yellowish discoloration of sclera, whitish. Yellowish discoloration of this sclera, skin and mucous membrane. Why? Because of increased deposition of bilirubin in these cells. Okay? So this is jaundice. Now this jaundice, normally every day we are producing 0.3 gram to 0.3 milligram to 1 gram, 1 milligram of bilirubin per 100 ml per dl. What is the normal? It is normal, 0.3 to 1 milligram per dl. If the level of this rises to about 2 to 3 milligram per dl, then there will be discoloration of the sclera, skin will appear yellowish, coloration of stool will be changed, coloration of urine will be changed. Okay? And this is called jaundice. Jaundice, also called icterus. Jaundice is also known as icterus. When you will be studying a patient and writing his sign symptom, if you find it is yellow, you will not find the jaundice present. You will write icterus present. You will write what? Icterus. Present or absent, positive or negative. Okay, so you have to know this term, icterus. Now the jaundice is only detectable signs can appear when this blood levels becomes 2 to 3 milligram per dl. You remember this. Jaundice is not a disease. Actually, where from this bilirubin came? Jaundice is excess bilirubin, and excess bilirubin came from different disorders. That's why the sign and symptoms of those disorders are actually jaundice. So jaundice is not a disease. Remember this. Jaundice is not a disease. Rather, it's a sign that can occur in different diseases. Okay? Jaundice. And how can you, can you identify what are the signs symptoms of jaundice? First, yellowish discoloration of the skin, sclera, and mucous membranes. Then light colored stools, pale stools. Initially, or normally it is yellow, but here it will be pale. Why? Conjugated bilirubin, urobilirubin is less coming. Less amount of this is coming. Why less? Liver is unable to process it. Okay, so pale yellow means liver is unable to process it. So there may be liver dysfunction. There may be hepatitis. So dark colored urine, itching. There will be itching because of bilirubin. There will be nausea, vomiting. There will be abdominal pain. There may be fever. There may be weakness. There may be loss of appetite. There may be headache. There may be confusion. Swelling of the legs in some cases, in extreme cases. So these are the signs symptoms of jaundice. And most of this you know it already. You have seen the patients. Okay? And epidemiology. And it is common worldwide. It is common. Affects all ages and sex. Infective type is more developing, more infectious. Because of infection, some RBCs died. There is hemolysis. And this type of jaundice, and from this hemolysis, jaundice developed. This type of jaundice is present only in the underdeveloped and developing countries. But in developed countries, they are more hygienic. So less infection. So they may suffer from other type of jaundice, obstructive jaundice. We will explain what are obstructive jaundice. Okay, in children, jaundice is there and mostly because of hepatitis. And this hepatitis A, B, C, and most commonly it is B hepatitis. Okay, elderly persons suffer obstructive type of jaundice, and sex, male, because most of the male, alcohol. And these alcohols are hepatotoxic, nephrotoxic. So hepatocytes become damaged. As a result, jaundice will be produced. So alcoholic liver disease, from alcoholic liver disease, there may be jaundice. And viral hepatitis and liver cancer also can produce liver cell damage. So automatically there will be jaundice. Female, gallstone, females, they are more prone to develop gallstone. 5F. One F stands for female, another F stands for fatty, another F stands for fertile, another ends fair. So, those who are having all these five, they are most likely to develop gallstone. And once they develop gallstone, they are likely to produce jaundice. How it produces, I will explain. These jaundice are of 3 types. How many types? 3 types. Remember, jaundice is a very important question for you. And it's a lifelong, in your clinical experience, you frequently will face this sort of patients, so you have to remember everything. So there are 3 types of jaundice. One is pre-hepatic. Before and blood before jaundice, before blood enters within the liver. So this jaundice occurred before it enters into the blood, into the liver. So that's why it is called pre-hepatic. So these pre-hepatic are because of hemolysis. So hemolysis can take place for various reasons. I will explain what are these reasons. Then intrahepatic, problem within the liver. And post-hepatic, problem beyond the liver. Liver has to secrete it in biliary duct. That is problem in the biliary duct. Okay. In prehepatic jaundice, What is the what level of bilirubin you will find? 0.3 to 1 milligram per dl. But in case of this type of jaundice, the bilirubin level will be much high, up to 20 milligram per dl. And in post-hepatic, it will be more, even more, 0.6 to 0.45, 0.45 milligram per dl. Okay. By seeing more bilirubin, okay, jaundice, but you for treatment, you have to diagnose what type of jaundice it is. Whether it is pre-hepatic or it is intrahepatic or it is post-hepatic. So this diagnosis you have to make. Suppose this diagnosis, your jaundice is due to obstruction of the biliary duct. You came to know it is obstruction. So you have to, for treatment, you have to remove this obstruction. But patient will be okay. In hepatic jaundice, you have to identify why. Because it is been infected by virus. So you have to treat the virus. Okay. So in this way, you have to identify what type of jaundice it is. Hemolytic jaundice. Prehepatic jaundice is because prehepatic jaundice is because of it is hemolytic jaundice. Prehepatic. It is causes of hemolytic jaundice means prehepatic jaundice. What are the causes? The intrinsic and extrinsic. One is intrinsic, another is extrinsic causes. Intrinsic causes means problem within the red cell. Suppose it is phagocytosis, membrane problem. Suppose it is elliptocytosis. This type of elliptocytosis is the problem within the membrane. Problem may be within the enzyme within the RBC. What is this? Glucose 6-phosphate dehydrogenase. Very important enzyme for, this is hereditary disorder, absence of this. This glucose 6-phosphatase enzyme. Hello? Anything wrong? Go and wash your face. This glucose 6-phosphatase enzyme is very important for RBC. RBC is not having mitochondria. It is having cytoplasm. Energy comes from only through glycolysis. Glucose 6-phosphatase, this is an enzyme. It is used in hexose monophosphate shunt, HMP shunt. And by this enzyme, one thing is produced, NADH. NADH. And this hydrogen, NADH, it is very important to safeguard the RBC from oxidative stress. Means from superoxide anions. Because the superoxide anions can damage the RBC cells, RBC cell membrane. And this is prevented by NADH, NADPH. This hydrogen actually derived from this enzyme, glucose 6-phosphatase. So if this is absent, the cell will not be able to protect itself from superoxide anions. Oxidative stress, the cell will die. Okay, so problem in absence of this may cause hemolysis. Pyruvate kinase, this is the last enzyme of glycolytic path. And in this reaction, phosphoenol pyruvate is converted into pyruvic acid. And enzyme is what? Pyruvate kinase. And in this step, ATP is produced. Now, if it is absent, will there be available, ATP will be available in the cell? Sufficient ATP will be available? No. So, without ATP, how the cell can work? So, that is another problem. So, that way, these will also create hemolysis. Hemoglobin abnormalities, we have seen. What? In sickle cell anemia, abnormal cell. Okay, abnormal hemoglobin, and also in thalassemia, globin chain, either absent or low in amount. So these are also abnormal. So they may cause hemolysis. So spherocytes, elliptocytes, sickle cells, normal hemoglobin, and how these sickle cells are obstructed, they are lumen, so they will be broken here. And the material will be taken up by the macrophages. So when these debris will be passing through the spleen, they will take up this. And extrinsic causes. There are 5 different types of extrinsic causes. One is RBCs are normal. Here RBCs are normal, but they are destroyed by different factors. 1, 2, 3, 4, 5. One is immune-mediated hemolysis. Hemolytic disease in newborn. Newborn babies often suffers jaundice. Why do you know? Because their liver is not prepared to conjugate the bilirubin into conjugated bilirubin. That is the cause. And autoimmune hemolytic anemia. Autoimmune, sometimes it happens. We produce antibody against our own body cells. It is antibodies are supposed to work against foreigners. But sometimes, because of suddenly my body started manufacturing antibodies that will kill my own body cells. It may kill my skin, it may kill my kidney. Lupus nephritis is the example. Lupus erythematosus. So these are skin disorders. Okay, so there will be inflammation of these organs because of this. So these are autoimmune diseases, and drug-induced penicillin, methyl dopa, they can also cause destroy the normal RBC. Mechanical destruction by a prosthetic bulb. Day before in our Wednesday class we described prosthetic bulb. When the blood comes in contact with the valves, most of the RBCs die or fragmented. Microangiopathic hemolytic anemia, MAHA. See, this is present. This is a capillary problem. This capillary, while passing through this capillary, they destroy the RBCs. Okay, and infection, malaria infection. Definitely, we have seen. So suffering from there is hemolysis, and because of there is increased production of this bilirubin. Snake bites, lead poisoning, copper poisoning, hypersplenism. If your spleen or splenomegaly, often you will find that in USG report, spleen is enlarged in splenomegaly. So when there is splenomegaly, there is increased chance of hemolysis, increased chance of development of bilirubin, increased level of bilirubin. Okay, not only this, platelet level also comes down. So increased size of spleen means hyperactivity of the spleen, means it will be destroying the RBC, it will be destroying or may accumulating, trapping. Sequestration means trapping of platelets, trapping of RBCs. This will not be available for circulation. So in blood, your levels of RBC will be less, levels of hemoglobin will be less. So these sort of things we'll observe. Hepatocellular jaundice. Okay, I'll explain this. Hepatocellular problem within the liver. One is viral hepatitis, alkaline liver disease, cirrhosis of liver, Gilbert syndrome, autoimmune disorder, not only skin, they can affect knees, synovial. Okay, it is called this. It can affect, they can attack the valves of the heart. So they can attack any tissue of our body. And toxin, different type of toxin, they are hepatocellular, they can develop hepatocellular jaundice. Obstructive jaundice. What is obstructive jaundice? See, from here, bile is secreted through this bile duct. You are not eating, so it will be coming here and will be stored here. Here, gallbladder is, what is the function of the gallbladder? It concentrates the bile. Concentrates the bile by absorbing water and adds mucus into this. That is its function. Okay. Then when you will be eating, then what will happen? The duodenum from the food, when the food enters into the duodenum, immediately one local hormone is produced, cholecystokinin 6CK. So this will be, this will be entering into the blood, through blood, it will be passing through the wall of the gallbladder and cause contraction of the vessels. So bile will be passing into the duodenum. Now, if there is one calculus, one stone at the path, will the blood will be, bile will be able to come? No. So you will develop jaundice. Okay. If there is any stricture, the cells, these cells undergone some changes. As a result, they join together, leaving no lumen. As a result, what will bile will not be able to pass. Again, here this is the pancreas. The head of pancreas lies here. If there is a tumor or there is a cancer in the head of pancreas, this will be blocked. So this type of, that will develop obstructive jaundice. So pancreas, head of pancreas. This is the body of pancreas, the tail of pancreas. Sometimes stones develop here also. This stone can come here. This stone can come here and block this part, leading to obstructive jaundice. See, this is the common bile duct. This is the bile duct. These are the stones. In USJ, these are the stones. So this, because of these stones, flow of bile is obstructed. There will be jaundice. Okay. In the gallbladder, stone is there. The wall of the gallbladder is inflamed. This may also cause, this is called cholecystitis. So this may also cause jaundice. And what is neonatal jaundice? I already told that liver is not developed enough to conjugate unconjugated bilirubin into conjugated bilirubin. Gilbert syndrome, small, it is not threatened condition. Suddenly, what happens because of some enzymes that conjugate the bilirubin, they will not be working properly. So there will be slight increase in bilirubin level. That is Gilbert syndrome. And Dubin-Johnson syndrome, MRP2. What is the MRP2? Remember? MRP2 responsible for active transport of bile into the biliary duct. So absence of these protein will lead to Dubin-Johnson syndrome. Okay? Now how will treat? Jaundice, we will find the cause. What is the cause? It is obstructive. You will try to remove the obstruction. If it is problem in liver, you will try to treat this. If it is hemolytic, pre-hepatic, then what is the cause? So this is the cause, you try to remove this. Okay. And in infant, phototherapy and blood transfusion is the treatment. And then, thank you.